Good morning, everyone. So I'd like to start by thanking the PAN Foundation for really giving me the opportunity here today to talk about a topic that I deeply care about. And before I begin, I want to thank my co-authors on this paper who are all in the audience today and share in my passion. I'd like to also acknowledge funding from pharma for this study. And I am so glad that this year the PAN Challenge zeroed in on asking for strategies, sustainable strategies, for providing access to critical medications. And this is so important an issue as it relates to specialty drugs. So, in terms of thinking about drugs that are often offering significant medical advances for patients with chronic, rare, and life threatening diseases, like the ones we use for cancers, hepatitis C, rheumatoid arthritis, multiple sclerosis. But these drugs are frequently subject to high out of pocket costs, as we heard earlier today from Tricia Newman as well. And particularly true for Medicare Part D patients who do not qualify for low income subsidies and are also called non LIS beneficiaries. These patients face extremely high and variable cost sharing, with out of pocket costs front loaded at the beginning of the calendar year. And I'll explain that to you in a few slides. Whereas, on the other hand, the LIS beneficiaries, these are low income patients who receive subsidies, face low stable cost sharing throughout the year. So, in fact, there's a growing body of evidence linking higher cost sharing with reduced utilization of specialty drugs in multiple disease areas. And many of these papers have been published by our research team that has particularly linked the high Medicare Part D cost sharing to all kinds of suboptimal specialty drug utilization patterns, beginning from delayed or reduced initiation of treatments, greater incidence of interruptions in treatment once patients start off, being poorly adherent, and eventually just quitting the medication completely. And we found this across a whole variety of disease areas in psoriasis, in rheumatoid arthritis, MS, and cancers. Now, clearly, while further research is needed, it is likely that this high cost sharing is placing these patients at compromised treatment outcomes. And before I start talking about deep diving into our own study, I want to kind of level set everyone in terms of what the current Medicare Part D cost sharing structure looks like and why we are finding some of the findings that we've reported in our previous studies. Now, Tricia Newman kind of showed you all a figure which was a vertical bar, and the way I like to present the Part D benefit is actually a horizontal bar because it really starts giving you a flavor of what cost sharing looks like for these Medicare beneficiaries as they move from January to December of a calendar year. So, to begin with, most Medicare beneficiaries might face some form of a deductible, a small deductible initially early on, and then soon enter the initial coverage phase. Now, as per CMS regulations, any drug that costs more than $600, this is the threshold that they've used for the last 5 years, and this means pretty much every specialty drug there on the market, can be placed on a specialty tier that can be subject to 25 to 33% co-insurance. That's a direct percentage of the price of the drug in terms of cost sharing in the initial coverage phase. Now, once patients hit what is an initial coverage limit in terms of their total drug spending, they enter what is called the coverage gap phase, where they face even higher cost sharing, ranging from 40% to 50%, depending on which year you look at in terms of the Part D benefit structure. Now, many of you might recall, and Tricia mentioned this in the morning as well, this coverage gap phase was also known as the infamous donut hole, where before the Affordable Care Act, patients were actually liable for 100% of the cost sharing for these drugs during this benefit phase. Thanks to the ACA starting 2011, the manufacturers are expected to give a discount on all brand name drugs. So specialty drugs would have a 50% discount. And the more important thing to note from a patient's perspective, though, is that the way the ACA set it up was that the manufacturer discount actually counts towards the true out-of-pocket spending that is incurred by the patient. And this is important because it is only when a patient hits a particular true out-of-pocket spending limit, also known as a catastrophic coverage limit, that the patient enters what is called the catastrophic coverage phase. And now they pay 5% in cost sharing. Now, most folks, including a lot of policymakers, think this is great because we have catastrophic coverage, we are giving great protection, and patients are only liable for 5% cost sharing. But the point to note here is that it is 5% of the price of the drug. And unlike every other patient who's insured in our healthcare ecosystem, including employer-sponsored enrollees or health insurance exchanges also, there is no annual out-of-pocket maximum for patients under Part D. So the patient continues to pay 5% until January 1st of next year. And guess what? Then the whole cycle resets. So I'm hoping by now we are all imagining this great roller coaster ride that these Medicare patients are going through throughout the year and year by year in terms of their out-of-pocket spending. So then diving directly into our study, what we first decided to do was, let's illustrate the real-world out-of-pocket cost patterns under the existing Part D cost-sharing structure for these non-LIS beneficiaries who face such high cost-sharing under Part D, because many individuals are actually not aware of the type of roller coaster cost-sharing that goes on for these beneficiaries. Next, we use the same patient-level data that we have and simulate what the out-of-pocket cost patterns would look like and how would they change if recent MedPack recommendations were applied, and I'll get to them in a second. And we also simulate how these out-of-pocket costs would change if our own recommendations were applied. So first, let's look at what MedPack's proposed changes were. So I have to say this because last year, the paper that won the first prize for the PAN Challenge, we had looked at chronic myeloid leukemia patients where we found that patients were not even initiating medications for their drugs when they were faced with high cost sharing. And one of the policy solutions we had proposed in that paper was instituting annual out-of-pocket maximums for these patients. At that time, I was thinking maybe this is an ivory tower idea because it's been 10 years since the Medicare Part D benefit has been in existence, since 2006, and nobody's really thought of that. But within 3 months, MedPack came out with the same recommendation that during the catastrophic coverage phase, we should eliminate the 5% cost sharing requirement for these patients, which is essentially instituting an annual out-of-pocket spending maximum, which is equal to the true out-of-pocket spending limit. Now, I'll just note here, because this is relevant for the data that we use for our study, which comes from the year 2012, that the true out-of-pocket spending limit was $4,700, and so that would be the annual out-of-pocket maximum that these beneficiaries would be subject to as part of the MedPack recommendations. However, MedPack also made another slight recommendation that does have implications, and when I show you our findings, you'll see why that's important. So what they proposed was that during the coverage gap phase, we would no longer credit the 50% manufacturer discount for the brand name drugs towards the calculations of the patient's true out-of-pocket spending. So our proposed changes were threefold. The first was in line with what we had suggested last year in our PAN Challenge paper, and in keeping with MedPack's recommendation that we eliminate cost sharing during the catastrophic coverage phase, and we create an annual out-of-pocket spending limit equal to the troop spending limit. So again, $4,700 in 2012. However, we propose that we should continue crediting manufacturer discounts for brand name medications towards the calculations of patients' troop spending. But most importantly is our third recommendation, which is dividing the annual out-of-pocket spending maximum by 12 to create a monthly out-of-pocket spending maximum. It's kind of smoothing out the costs akin to payment options offered by energy companies for heating bills. So real quick, as I mentioned earlier, we used the 2012 data. That was the latest year of the data available to us in-house at the time of the study. And these were 100% Medicare claims for all fee-for-service patients who were not eligible for low-income subsidies and enrolled in Part D, and were full-year users of 3 of the top spending specialty drug categories. So for illustration purposes here, we picked rheumatoid arthritis, multiple sclerosis, and chronic myeloid leukemia. So diving right into the results here, this slide essentially shows you the problem of too much, the too much part of our story here, that beneficiaries face very high cost sharing when they are using specialty drugs under Part D. And so what you see here is that rheumatoid arthritis patients face a total annual out-of-pocket spend of $3,900, and it keeps going up for MS, up to $6,300 for patients who have chronic myeloid leukemia in one given year. And as you can see here, the other point to note is that more than 90% of the costs for all these beneficiaries are actually due to the specialty drugs, as is highlighted by the blue shading in the bar charts here. Now, this slide talks about the importance of the annual out-of-pocket maximum and why having 5% catastrophic coverage cost sharing is still problematic. Because what you find in this slide is that even during the catastrophic coverage phase, these patients are basically spending out of pocket anywhere from $1,200 for RA patients to $3,500 for CML patients. And this red line on this figure is essentially telling you that 31% of the total annual out-of-pocket spending for RA patients actually happened in the catastrophic coverage phase. So that's about 1/3 of the spending was actually in the phase that is supposed to protect you from catastrophic expenses. And in fact, it's even worse for the CML patients, where 56% of their spending actually happens in a phase that, at least in name, sounds like it should be providing financial risk protection. So now let's switch over, having looked at the too much problem, to the too soon problem that we wanted to talk about in this paper. So what we've done here is mapped out, using our real-world patients in our data set, what their cost sharing looks like month by month. And here on this figure, I show you only the RA patients to start off with. And what you see is that these patients, just in the first month alone, have an out-of-pocket cost sharing of $977. Recall, their total out-of-pocket spending was $3,900 during the year. So that's 25% of the entire year's spending happens to be in the first month. By the time they're through February, they've already spent 50% of their total annual out-of-pocket spend in just 2 months. We see the same story for MS, but much higher costs. MS patients pay up to 30% of their out-of-pocket costs, annual out-of-pocket costs, in January alone. And even worse for patients with blood cancer, CML. And what you find here is that just in January alone, the patients are facing $2,400 out-of-pocket for their first monthly prescription, which is, by the way, twice the average Social Security income that beneficiaries receive. So we can clearly see the problem. And then while the costs taper off for many of these conditions, they're still incurring substantial costs in the later months. So in this slide now, I'm just putting all the 3 numbers together so that we can see, as I move on to the next slide, it's a visual effect now, to see how the costs would change if Medicare's MedPacks recommendations were implemented. So watch carefully. What do we see? Mixed effects, right? So the MedPack recommendations are definitely solving the too much problem. They're instituting an annual out-of-pocket maximum, so after the beneficiaries would hit $4,700, so our simulation uses the same 2012 data that we had available. So we are applying the $4,700 annual out-of-pocket maximum. So about May onwards, they really have minimal or no costs. But what are they doing in the earlier months? They're actually exacerbating the out-of-pocket liabilities just in the first 3 months alone in January, February, March. And that's because the manufacturer discount no longer gets counted towards the true out-of-pocket spending limit, which is when they would hit the annual out-of-pocket maximum. So these patients are actually spending more time and more money in the donut hole or the coverage gap phase. And that's what's causing this problem. So our very simple and intuitive solution essentially solves for this. And you see that with the dotted line. So what I have in the bar charts behind is still what the MedPack cost would look like. And then what I show you with the dotted line is essentially instituting a very simple monthly out-of-pocket spending limit where all we've done is taken the $4,700 and divided it by 12. What we are doing is we are getting patients to just pay a maximum of $392 out of pocket in each month and providing stability to these patients throughout the year. Now, clearly, one of the things that the PAN challenge had also asked for was thinking about what would be the incremental cost of implementing such a strategy, and would this be financially sustainable? So without really getting into the details of the methods here, basically what we did was we got publicly available estimates to estimate what would it take to provide this kind of coverage to all non-LIS beneficiaries, not just the 3 disease samples that we studied in our particular study here. And essentially what we find is that the incremental cost per beneficiary per year would be $24 only. That is $2 per month per patient. And in practice, in terms of thinking about how this would work out, the increased cost would not necessarily be a straight pass-through cost via increased premiums for the non-LIS patients, but would be borne out through the Part D plan bidding process, so would in fact turn out to be even a lower cost burden for a lot of these patients. So in summary, some of the major takeaways from our study are that, firstly, in the current environment with the existing Part D structure, patients face substantial financial burden. It's essentially too much, and it happens too soon. The MedPacks proposal would have mixed effects. It would help patients who reach the catastrophic coverage limit in terms of reducing their spending, because then they incur no costs. But for patients who do not reach the catastrophic coverage limit, they might actually spend more because they spend a longer time and more money in the coverage gap phase. And regardless, for all patients, it exacerbates financial burden early in the year, creating issues. Our proposed strategy would essentially distribute costs evenly across the year and likely increase patients' ability to meet cost-sharing obligations. And the strategy has manageable incremental costs regardless of the ultimate financing mechanism. Now, the one thing that critics of this suggestion might say is, this is going to be so complicated for the pharmacies to implement, the plans to keep track of, like, the first month's copayment is $2,400, but the patient only pays $400. We need to track the $2,000 in balance across the months, across years, perhaps, depending on when the costs are incurred. But my answer to them is very simple. Working out the logistics of implementing our strategy are truly a worthwhile goal, given what we are seeing here. And in fact, much of the rest of the healthcare system bills patients for remaining out-of-pocket costs after a service is rendered. Besides your physician visits where you pay an upfront copayment, you receive your lab bills, you receive your hospital bills in the mail after the fact. It's only in the case of prescription drugs where the patient is required to make all the payments upfront at the pharmacy. So why not? And that's my role question. I'm not going to get into the caveats. The paper is going to be published in 2 weeks, and we fully acknowledge that anytime you do a simulation model, you have to make assumptions, and we have to know how that assumptions might basically impact our results. But I'd just like to end with saying that specialty drugs represent vital treatments for patients who often have few or no effective alternatives. And while they offer these options, treatments can only be effective, and patients can only derive true benefits from these if they can actually access them. And so Medicare Part D policies that support access and adherence are critically important and should include attention to both the amount of cost sharing and the timing of the cost sharing. Thank you.